Pattaya City Expats Club is a non-profit social organisation and our speakers are volunteers. The club as such assumes no responsibility or liability for the professional reputation of or the quality of services provided by the speaker today.
Thank you so much, Dr. Moore, for coming. Yeah, she's really thorough, and everybody has only huge praise for this doctor. So thank you, Dr. Moore, for coming in and bringing us to our eyes, closer to our eyes. Come on, welcome, Dr. Moore.
ขอบคุณมากค่ะ สวัสดีค่ะ Hi everyone, my name is Dr. Bunyaporn Chandra Chamnong, or you can call me just Dr. Moore for my nickname. Yeah. Okay, today we're going to talk about the vision wellness. Okay, let's start. Okay, this is me. I'm the founder of Glassisimo Optical. It's the eyewear clinic in Pattaya. I'm the board certified ophthalmologist and vitreoretinal specialist. I worked in Pattaya for more than 13 years, but I spent time around this eastern region for more than 20 years after I finished my medical school from Chulalongkorn University in Bangkok. Why eye health is essential for longevity? Because our life expectancy longer. Gradually, from 1950, we live longer every year. And in 2026, both sex life expectancy is 73 years old. For female, we live longer, 76. For male, globally, 71 years old. But the vision loss is not accepted as an inevitable part of aging. Untreated visual loss increases the risk of dementia and falls, and many age-related eye conditions can prevent and even treatable. The globally leading cause of vision impairments, number one cause is refractive errors. The second, cataracts. It's highly treatable. The third one is diabetic retinopathy, also preventable. The fourth one is glaucoma. And the fifth one is age-related macular degeneration, which is the leading cause among the developed countries. Over 80% of all vision impairment is preventable or curable. Yeah, it's essential for longevity because vision can prevent fall. Poor vision double the risk of falls and fractures, leading cause of functional decline in seniors. The second, cognitive health. To maintain the cognitive health, you need good eyesight. And with visual loss, increase the risk of dementia and Alzheimer's. And to maintain your independence and quality of life, you need eyesight preserved. You need the social connection and mental well-being. Okay, let's go through the eye anatomy 101. I will make it simple. Imagine that your eyeball is like a sphere or a bowl full of water. We have the sclera as the wall wrapped around the eye, and the front part, cornea, is like a front window. Allow the light go through the retina. And we have the crystalline lens here, a structure made up of fibers, usually clear and transparent, allow the light focus perfectly on the retina. And then in the back of the eye, we have the retina. This is the photoreceptors layer lining at the inner part. And the center of retina called macula, responsible for the central vision. To have good eyesight, you have to have the macula healthy. And then after the photoreceptor receives the signal from light, it transfers to the brain by the optic nerve, works as the cable wire. So we should have the comprehensive eye examination. It's not just reading the number chart, but it's the complete health check for your eyes, starting from the visual acuity test without the correction, without glasses or contact lens, and with the correction, pinhole or glasses to find the best corrected visual acuity in each eye. Second, take the eye pressure measurement. This is a screening test sensitive for glaucoma eye condition. Advanced refraction. To get the precise vision sharpness, we do the refraction test and choose and do the binocular vision check to balance both eyes. Then go to the slit lamp biomicroscopic examination. Look for the ocular surface, anterior segment, including cornea, iris, and lens, and then the posterior segment, vitreous, retina, and optic nerve. In some cases, the ophthalmologist will ask you for a dilated eye examination to see more detailed fundus. And other additional tests, OCT scan, cross-sectional scan to see the macular, fundus camera, and ophthalmic ultrasound. Okay. Refractive errors. It's happen when the shape of the eye cannot bend or refract the light properly. In the ideal case, our eye refracts the light on the retina, exactly on the macular center of the retina. This is called emmetropia. Okay, when the light perfectly bend or refract to the retina, we call this condition emmetropia. If not, we have 4 common types of refractive error, starting from the myopia, hyperopia, astigmatism, presbyopia, which is age-related. Okay, let's start with the myopia or nearsight, short sight. It generally begins in childhood. If you are short sight, distant object will look blurred and nearby tasks remain clearer. And the eyeball structure is too long because the refract light focus before the retina, not right on the retina. The hyperopia, long-sightedness or far-sightedness. This is different from myopia. Near objects become blurry while the far-off details are sharp. Because the eyeball is too short, the refracted light focus beyond the retina. My hyperopia in young people will not need any treatment because when we are young, we have very high accommodative power. Our eye muscles are strong. We can refocus easily. But when we grow old, some hyperopia cannot be compensated anymore. You will need glasses for the distant vision. Okay. I just want to make it simple about the development of our refraction. Almost all the babies are born with far sight because their eyeball is small and short. So we have the autogene mechanism process. This is the emmetropization. When the light focuses on the retina, it happens during our infancy and early childhood. It brings the light to focus back on the retina while the eyeball of the baby grows bigger or longer to refocus the light. And it explains the cause of myopia because now we have too much close work, homework, reading, and writing, and too little time spent outdoors and less exposure to sunlight, and also the genetic from the parents. and prolonged use of tablets and smartphones. This triggers the eyeball to grow longer than normal because the child only focuses at near tasks. Myopia problem in the next 30 years will affect most of the population, about 50% in 2050. But now we can manage myopia progress by using the defocus glasses. The defocus glasses bring the peripheral light on the retina to focus on the retina and reducing eyeball length growth. So it stops or holds myopia progression effectively about 60%. And some patients may choose to have low-dose atropine eye drops, daily dose to slow down the elongation of the eye. What about astigmatism? Astigmatism is when your eyeball is not truly spherical. It's an oval shape, like a rugby ball more than a football. So the different plane of the curvature in the vertical and horizontal has different power, and that reflect the light to different focus, causing blur vision at all distance. Aging eye, presbyopia is not the same thing of hyperopia, because presbyopia happens to anyone with short sight, with far sight, or someone with emmetropia or normal eyes before, but we all get presbyopia when we are aged, starting after 40 years old, because our accommodative power declines significantly after 40 years old. You have to bring the menu far enough to focus, and you will have ocular fatigue, eye strain on close object. The safest option to correct refractive error is to wear glasses. And we have 3 different structure of glasses to choose. First one is single vision. The second one bifocal, and the third one is progressive addition lens. Single vision lens is simple. It corrects only one distance, far or near. Bifocal, you will have 2 points of focus, far and near, but you don't have the intermediate vision, which is our arm length or the computer distance. And you will see the image jump by shifting the focus. While the progressive lenses, it has smooth transition through distant, intermediate, and near vision. So it's more aesthetic design. There is no sharp point of the thick lens between the top and the bottom. Okay, this is how the progressive lens work. Every progressive lens has this structure. The distant top zone, when you look straight, is for walking, driving, distant objects. The middle zone, when you look down a little bit, is for working on computer, cooking, or doing makeup. And the bottom zone, when you move your eye down there, you will see the near vision for reading and for smartphone use. But every progressive lens, it has limitation at the side, both sides. This is a distortion zone. And each progressive lens type has different design depending on this zone. If the good one, you will see less distortion because they bring the distorted zone away from your eye, and it costs more expensive. Okay, you may heard about this reading eye drop. It just launched last year, aceclidine, 1.44%. Daily use, and it lasts up to 10 hours. The drop constrict the pupil and creating pinhole effect for temporary near work, but you have to use it every day. This is the first FDA approved to treat presbyopia. Digital eye strain and the blue light myth. Digital eye strain. Nowadays we have more problem from the digital gadgets. Extended time on screen causes dry eyes, blurred vision, headache, and neck pain. Ophthalmologists recommend you to use 20-20-20 rule to relieve digital eye strain. Take a break every 20 minutes and find the object far away to focus, 20 feet away to relax your eye muscle, and stare at that object for 20 seconds, then resume to your near work. That will reduce the eye strain. Blue light. Have you heard about the blue light is harmful to the retina? It's still in the theory because the research only found that blue light disrupts our sleep cycle, the melatonin. But the blue light from gadgets is not intense enough to destroy our photoreceptor. That happened in the lab, in vitro study. They use high-intensity blue light beam to the photoreceptor. But the blue light also scattering from the digital screen, and that makes your eye strain because you have to refocus more often. So the benefit of blue light blocking is to reduce the digital eye strain and improve your sleep cycle and melatonin. Now, let's understand the cataract disease of the lens. Everybody gets cataract when we grow old. The lens has two parts, the cortex, superficial part, and the dense nuclear, deeper inside. The nuclear part starting to become more dense as we age. From the transparent clear lens, become light yellow, deeper, darker yellow, and even dark brown or black cataract. So, cataract is the cloudy, opaque lens, and we have cataract grading. The immature one, partially opaque lens, the mature, completely opaque, and another two, hypermature and more gagnant, is the high-risk complicated cataract. Normally, we don't wait until, nowadays, we don't wait until you get mature cataract, then we do the cataract surgery. We usually recommend to have it done at the immature state. But for the immature cataract, also has 4 grades. Start from grade 1, 2, 3, and 4. Some patients with grade 2 may have visual disturbance, but some don't. So we need to have comprehensive eye examination for the detail and then discuss about the risk and benefit of cataract surgery. Because most of cataract patients may improve the vision by glasses. You don't have to go to cataract operation for all. The cataract type and the risk factor. Okay, we will focus mainly on the age-related cataract, which is the most common type after age 50. And these are the risk factors for the age-related cataract. From the UV exposure, chronic unprotected UVB ray, oxidative stress, free radicals, medical condition, diabetes, uveitis. And these medications increase the risk of cataract. Other type of cataract, traumatic, secondary cataract, ocular symptoms from cataract usually start with fuzzy vision, like dirty glasses. Decrease the color, contrast. You may see glare and halo at the nighttime. Do you know about the cataract operation? This procedure has the name phacoemulsification. This is the gold standard cataract surgery nowadays. Some doctors may rename this procedure to many trade names, but it's also the same thing, phacoemulsification, which is we use the micro incision about 2 millimeters and use the ultrasonic probe to dissolve the cloudy lens inside the eye to liquid and suction out through the small incision. After that, we use lens insertion by a foldable intraocular lens inserted into the capsular bag through the small incision. So this procedure requires no suture, and it's safe, quick, only 20 to 30 minutes. Okay, I want to show you about the types of intraocular lens we use. Normally, standard intraocular lens or the monofocal. The standard lens gives you excellent vision at the distance only, but you will need reading glasses for sure. And the premium one or the presbyopia correcting lens, we have 2 types. The first multifocal lens or the trifocal lens. This has 3 different focus, distant, intermediate, and near. But it has visual side effects. The most common is glare and halo at nighttime. So if you need nighttime vision or you need to drive at night, you may not suitable for this one. You can go for extended depth of focus or EDOF. The EDOF is kind of hybrid lens, more forgiving. It gives you good distant vision, intermediate, and some near vision. Not as good near vision as the trifocal, but it has very low night vision side effects. This is the structure of each kind of lens. The standard monofocal, plain. Multifocal or trifocal has different focal zone there, and the extended depth of focus. Before you go to make a decision about cataract surgery, the doctor should talk to you, ask for your lifestyle, behavior, and do you need reading glasses independent? Because monofocal can give you to a little bit of intermediate vision only. Multifocal can give you all range of vision. EDOF or extended depth of focus, good distance, good intermediate, and a little near vision. So to have spectacle-free after cataract surgery, we have the data. 80% of patients of multifocal lens will have spectacle-free, but the rest, 20%, will need reading glass. So there is nothing 100% in medicine. And these are the side effects at night from the multifocal. You will see glare, halo, or starburst. You can see this is the visual side effect can happen. But most of the patient can adapt to it because we have brain adaptation or neural adaptation. Less than 5% may not have good adaptation enough. So EDOF is another alternative choice to minimize visual side effects. We can also correct the astigmatism during the cataract surgery by including the toric IOL into the implant. The patient who has higher astigmatism more than 0.75 diopter usually do not need toric lens, but more than 0.25 diopter, especially the premium lens, we should consider to add the toric correction. because we are in the precision era of medicine, we just don't need 20/20 vision, but we want also the quality of it. Okay. Another common eye disease, diabetic retinopathy. It has two main types, the non-proliferative and the proliferative. This is the early stage when blood vessels start to leaking fluid or bleeds. But there is no abnormal blood vessel that grows on the retina or neovascularization. This is a picture of patient with advanced stage of diabetic retinopathy with abnormal blood vessels, neovascularization. This condition triggered by oxygen deprivation of the retina, a chronic oxygen loss for a long time, and our body start to produce new blood vessels, and these vessels bleed easily to vitreous, causing vitreous hemorrhage. If you have diabetic, you should have eye check every year. If you don't have any diabetic retinopathy, you can continue to follow up every year. But in case you have non-proliferative diabetic, mild, moderate, or severe, you should have your eye checked every 3 to 6 months, because another condition which is quite common for diabetic retinopathy is diabetic macular edema. Macula is the center of the retina, and it has a lot of blood vessel there. Diabetic blood vessel leaks fluid, lipids into the retinal space, causing swelling of the macula. We are now in the anti-VEGF era. Most of diabetic retinopathy treatment can have anti-VEGF therapy without laser photocoagulation or surgical intervention. We do eye injection. Very simple. In the office, it takes only 5 minutes to deliver a small dose of medicine into the eye, in the vitreous. Okay, the next thing is eye stroke. Our retina has two different circulation systems, the vein and the artery. This one is the medical emergency because when the blockage happens, you will lose the vision suddenly and has no pain at all. Usually happen in one eye. Most patients, they will feel like they can wait. They can wait to tomorrow or next week and then come to the ophthalmologist. But that's too late. We cannot do anything. In case of you have the vein occlusion, this is less severe because the vein takes time to start back pressure and bleeds. In this type, normally we use anti-VEGF injection to stop the leaking, bleeding, and stop the macular swelling from the leaking fluid from the veins. To remember, B fast, side of stroke, B for balance, E for eyes, change in vision, F, face, dropping, A, arm or legs, weakness, S, speech, abnormal speech, T, time. I is an neural organ. So eye stroke is one of the side of brain stroke. You have only 90 minutes, the highest chance to restore the retinal function, and only 4 to 6 hour limit for the tissue survival. So go to emergency room immediately if you have painless visual loss, especially in one eye. Next is the AMD, age-related macular degeneration, one of the leading causes of vision impairment in developed country. AMD will destroy the central vision. You may see shadow at the center of the eye, distorted, wavy lines. And this is an amsler grid, a simple self-check at home. So if you see this kind of picture, blurry at the center, distorted vision, shadow, blurry, go to see ophthalmologist and check for the macular health. Two types of AMD, the dry type and the wet type. Dry AMD is slow progressive, but there is no cure. Prevention, use the vitamin supplement ARES2 formula, vitamin C, E, zinc, lutein, and zeaxanthin. The wet type, severe form, abnormal blood vessels under the retina grow and bleeds into a subretinal space, and this requires anti-VEGF injection to save the eye. So remember to check yourself with the amsler grid. Use one eye at a time. Look at the center of the grid. If you see wavy line, loss of the grid, shadow, or anything abnormal, go for comprehensive eye examination. Risk factor, cigarette smoking, number one risk factor for AMD. Obesity, hypertension, diabetes, and UV exposure. These risks, we cannot do anything, age, family history, and Caucasian. But these are preventable risk factors. Okay, now we have open session for Q&A.
I would just like to start off by saying, wow, what an informative presentation. One of the most informative and clear presentations we've ever had. Wow. Seriously, not an exaggeration. So, anybody got some questions?
Good morning. Thank you. My name is Alan. Thank you very much for a wonderful presentation.
Thank you.
I have a question about UV. I do about 2 hours of walking every day, and sometimes it happens to be during the high sun in the afternoon. Should I be wearing anything to protect my eyes? I do wear a hat that, creates a little shade on my face, but should I be doing more, or am I damaging my eyes by doing a 2-hour walk every day in Thailand?
I encourage you to keep walking, but you should wear sunglasses to protect your eyes. That is not enough to protect our lens and the retina from the UV light.
Glasses.
Oh,
Cheap ones.
cheap ones. Okay. You can visit my eyewear clinic, Glassisimo Eyewear Clinic in North Pattaya. We have sunglasses. We have the special sunglasses like a polarization lens from Malvigim brand. Yeah, Under Armour. You can test and try there with good price.
Okay, well, hopefully that'll be in next week's newsletter, exactly where you're.
Thank you for your talk. When you do a lens replacement after cataract, how do you feel about the recommendation to do a slightly more convex lens for the close-up on one side and slightly more convex lens for the distance on the other side, so you won't need eyeglasses altogether once after you got the lens replacement?
Okay.
That's my personal experience.
Yeah, right. You're talking about the monovision technique. We aim one eye, mostly the dominant eye at distance. And for near work, we use a non-dominant eye. That is one of the technique quite common to use. But in my opinion, if I prefer to correct both eyes perfectly clear at all distance, because we need binocular vision. To use monovision, you switch from one eye at distance and one eye at near. It's not true binocular vision, but it works in some cases. I didn't mean it wrong. We have to tailor and discuss to each patient because some of the patient may not a good candidate for the multifocal lens, but they're a good candidate for the EDOF or hybrid lens. But the hybrid lens cannot give you perfect near vision. That's why we do monovision in the case of EDOF implant. Yeah. Is that clear?
Two questions. Number one is I've read articles that a lot of those cheap sunglasses that you find out, and selling along the streets and so forth, they might say polarized or UV protection, but if you test them, they actually don't have any protection. Is that a risk where you end up with way more UV because now you're getting more of the sun's rays, but you're not getting the protection with the lens?
Yeah, correct. Because cheap sunglasses, only the tint glasses, darker colors, it even more damage your eye because darker lens, your pupil will be dilated, allow more light and the UV go through the eye, and it cannot have any protection.
Okay, thank you.
We have the UV test and the polarization test at our clinic.
The second question, I never realized before, those pictures of the lenses you use for replacement, they have those little arms on them. Is that to keep the lens from rotating, or in the diagrams, it looks like there's little arms sticking out?
Right. That's called the haptic of the lens. You can see the C-loop haptic, 2 arms, right? And this arm will prevent the rotation because the arms extend to the capsular back 180 degree expanded.
Oh,
and
you.
it has good rotational stability proof worldwide.
All right. Thank you very much. Yeah. I feel like I went to a university class. Appreciate it.
First of all, thank you very much for coming. Excellent presentation, as well as your booths out there. I had a question. The flashes and floaters. I heard if you had those, that it could be a sign of retina detachment.
Yeah, good question. I'm the retina specialist, so I do eye examine with the patient who has floaters, flashing every day. Floaters is the vitreous degeneration. Everybody will have floater at some age. We cannot avoid it because the vitreous also age like our skin. So, but most of the floaters will not cause you anything, will not make you blind, but it's just disturbing the vision. Some of the floater with flashing is the warning sign for the vitreous traction, and that can be the retinal tear, and that needs the treatment. So if you have floaters or flashing symptoms, just have your eye examination with retinal specialist. We will do the fundus, detailed dilated eye examination, look for the vitreous, and screen for the retina problem, 360 degree to the peripheral retina, and make sure that you don't have any pathology that needs laser or surgical intervention.
Okay, Doctor?
Thank you for your talk and for the people outside taking the job to check my eyes and the other people. And my question is, I think it is better don't take sunglasses. What do you think?
Better
not to use sunglasses.
Oh, do you have any reason?
Yeah, because God, they don't give you the darkness. They give you the light.
Oh.
I see. 50 years ago, when I was a young boy, nobody had sunglasses. They don't need it. Yeah. And now people you say in a disco or everywhere, you see they wear dark glasses. I don't feel that it's good. It's my opinion. Thank you.
Thank you for your opinion. But we have the scientific data that the UV light damage to the lens and the macula, increasing the risk of cataract and macular degeneration. This is proof, scientific data. So it's your option to choose to wear or not to wear sunglasses.
Doctor, when you who were showing the lens, the replacement lens with the two arms. I was surprised to see that. In younger people, if they have a replacement lens, do they have to be careful about things that they do? You know, hobbies, boxing, banging their head. Could there be a rotation?
Normally, the rotation will be stable after 1 month of surgery. So during the first month, you are informed to avoid impact activity, no lifting heavy things, take good care of your eye to avoid the rotation. But after 1 month, the capsular bag will become adhesive, stick to the lens and prevent rotation. So after 1 month, you just take care of your eye just like you have normal lens. Avoid trauma to the eye.
Thank you, Doctor. Very informative talk. About 9 months ago, I had the toric lens replacement and at Bangkok Pattaya. And I do experience some dry eye, and I put drops in my eyes usually 2 or 3 times a day, sometimes a little more. Is this something that is common with, because I never had this symptom previously, is this common with lens replacement? Does it stop, or is it something that continues a lot? If I'm doing a lot of computer work, it's exacerbated more. But if I'm not doing computer work, maybe not so much.
Okay. Dry eyes, very common after cataract surgery because we made an incision at the temporal side of the eye, and that cuts the corneal nerve. But the nerve can be regenerated after time. So 9 months, perhaps we still need to use artificial tears, lubrication.
Yeah.
And your work on screen also decrease your blinking rate.
Right. Yeah.
So
okay.
keep
So it
blinking.
might fix itself in time?
It will fix itself in time,
Yeah.
but may not 100%.
Right. Okay.
Because the nerve reflects on the cornea. It will come back, but I cannot predict that every patient will have 100% recovery.
Okay, thank you. And I'd just like to comment on our good friend's comment about God created us without sunglasses. He also created us without toothbrushes and toothpaste. Thank you.
Over here.
Thank you, Doctor, for that very scientific explanation. Very well said. My question is, I've been a contact lens user for like over two decades or 3 decades. I had a lot of eye check and eye tests happening in my eyes already. It's quite interesting to know all those. But as a general question for everyone also, being a doctor, what do you advise a client or a patient as to take care of your eyes daily, apart from wearing the good eyeglasses, branded ones, outside when it's for the UV protection and all? But about maybe diet or about sleeping, because we cannot avoid the digital world now, gadgets and everywhere. Like for instance, if you are in Singapore, young kids are already having myopia and all. Good thing to know that as we age here, then we get myopia and all those problems. But how about the young ones? How do you advise your patients? Thank you.
Okay, that's a lot of questions in one. Okay, let's start from the young generation, the child. We are encouraged more outdoor time because it will prevent myopia, and more myopia increasing eye disease when we are adult. So spend more time outdoor, less near activity, exposed to sunlight with good protection. That's for the child. And for adult, everybody age, so we cannot prevent. But keep good control of your blood pressure, your blood sugar, your cholesterol, and if it's possible, stop smoking. Because smoking is the major risk factor for all eye disease.
Thank you very much indeed for your presentation. It was very informative. I had no idea, that was a pun, I had no idea that...
That was a joke, idea.
Yeah, that was, yeah. I had no idea of the extent of the information that was available. Has the treatments progressed so much in the last 10 years?
Yeah, What kind of treatment?
Any treatment. He's just stunned by the progress in eye treatments. Yeah, the last 50 years or so, it's been absolutely.
I would say in our retinal specialty, we have anti-VEGF. It's one of the breakthrough innovation because various of eye disease can be treated with anti-VEGF injection, and it prevents visual loss effectively nowadays. And even more in the pipeline, there are many forms of injection, small, slow release dose, implant in the eye will come, and even more genetic therapy, gene therapy for eye degeneration. And intraocular lens technology also improved a lot in the past 10 years. We have better optics, material, rotation stability, and less visual side effect from the multifocal lens. Even the EDOF one is more coming and promising future.
Yeah, thank you very much for talk. Can you tell me how many different types of lenses you have, for instance? Because you know, when we were young, we could see and we could vary our focus and everything, and these cameras only have one lens. So are we ever going to get the time where we can go in and we just decide whether we're going to have it brown or blue eyes, you know, and the lenses are the same? Is there any chance of that happening?
Brown or blue eye is not from the lens. It's come from the organ called iris. Acts like a diaphragm. Lens is clear, no color, but in front of the lens you have iris organ, small hole with colors. That's the iris. The lens that you mean, maybe you mean about the intraocular lens, right? Or the glasses lens?
Different lenses you have put in your eye. How many different types?
Okay, we have 3 main types. The standard one, monofocal, single vision lens. The second one is multifocal lens or trifocal. The third one, extended depth of focus, EDOF, hybrid one. These are 3 main types of the intraocular lens nowadays.
Hi, most of the top ophthalmologists in the US now are placing the Invista Envy multifocal lens made by Bausch & Lomb. Kind of wondering, you know, based on patient outcomes, I'm wondering if that product is available in Thailand. And my second question would be about what percentage of your patients these days are opting for the multifocal technology versus EDOF or toric or plain monofocal?
Okay. In my practice, 30% of the patient will need to go for the toric astigmatism correction lens, and about 60 to 70% go for the premium presbyopia correcting multifocal or hybrid EDOF one. And yes, we have Bausch & Lomb IOL, and we have other brands also, which is differently works on different patients. You have to choose the best one that suits for your lifestyle.
Hi, Doctor. Just a quick one. Can you explain to people what a master eye is? Because I think some of them may not know how to identify their master eyes.
Dominant eye. Okay. When you look at the objects at the distance, like when I look at the 5 exit symbol there, to identify the dominant eye, I will do the triangle like this in my hand. And use this triangle, cover the object at the distance, make it at the center, with both eyes open. Something far away, yeah. Keep looking at it, and then close one eye at a time. The dominant eye is the one eye that you still can see, that symbol.
Thanks for a very comprehensive talk on eyes. A while ago, I had cataracts in both eyes, and I had my lenses replaced. So my question to you is, how long do these lenses last before you get any deterioration? Thank you.
The implant made for lifetime. It can last for your lifetime. If you don't get punched into the eye, it will stay there, stable enough. No degradation, because the material is proof to be stable and last long. But after insertion of the lens, some patients may have after cataract, which is the capsular fibrosis. The posterior capsular bag opacity can happen in anyone, but nowadays we have the technology, the age of the implant to prevent that PCO or after cataract better. So some patients may need to do laser for after cataract to open the capsule behind the lens, but some don't. Depend on the implant you choose, the model you choose.
Hello, my name is Alex.
Hi.
Thank you for your time, for great information. I almost feel like a doctor. However, it's missing one more information for me. What should we do to maintain a good health for the eye? What should we eat? Maybe carrots or vitamins? What should we do about that besides the outdoor activities?
Okay, you can eat normal food, but try to eat more antioxidant. That will stop the free radicals. Vegetable is good for the eye. Sugar is not good for the eye. Too much fat is not good. Salt, not good for the eye also because it increases our blood pressure. So we usually recommend, same as the heart doctor said, Mediterranean diet, natural food, less processed food.
And on that general health note, I think we've come to the end of the Q&A. Yes, another round of applause for one of the great talks we've had at the club. But wait, there's more, because we've got a lucky door prize, which I bribed people to win, but I don't think
Okay, the first one.
Do we have 10 lucky draws now?
I wish we had this up on screen. This is very unique. Usually we draw things out of a... Junichi Kono. Junichi Kono. Oh, konnichiwa. Oh, konnichiwa. Okay. You get your prize is coming to you. Oh, here we go again. John Harrigan. John Harrigan. Yeah, I think so. I think it's the. No, this is the Thai version of your name, John Harrigan.
Thank you.
Okay. Joe Haddad. Joe Haddad. Hey, Joe. Here we go again. David Lee, ho-ho! Multinational winners, China, Japan, all over the place. John Horrigan, America. Frederick Rettinger. Where are you from, Frederick? Detroit. Oh, sorry about that.
So 5 left.
5 left, there's more. Alan Randall. Alan Randall, come on, put your hand up, Alan. Where is he? Oh, yeah. Our favourite bar owner. Raymond Lothian, my friend. Come on up, Ray. Oh, stand up, they'll bring it to you. He's only been back in Thailand about 6 weeks. Robert Forsyth. Yeah. I was going to say, yeah, who the F is that? Yeah. Anthony Brabin. Anthony Brabin. Oh.
The last one.
Last one. Lucky last. This is great. I love this spinning thing. It's amazing. Drum roll. Alan Bryan. Alan Bryan. Hey. Well, we've been around the world with all the winners here. It shows you how multicultural. Tanya, stay here for a second. Come up. Tanya, yeah, bring that up to me. She's my personal assistant. All right. Well, of course, we have a very small token of our deep appreciation of this wonderful, wonderful talk. Okay, be honest. Put your hand up if you didn't learn anything today, right? I don't think we're... Yeah, I shouldn't think so. No hand went up. It was so informative. Please come up and accept this, please. It's a small token of our very deep appreciation. Thank you, Dr. Moore. It was really, really wonderful. And of course, I'm sure there was so much information there that was new to us. Of course, the video will be up when Brad has time to do it. So make sure you're on the emailing list for the club. Go to pcec.club and join the newsletter list. And then when it's on, as soon as it's up on YouTube, the video will come out and say it's up on YouTube. So I'm going to watch it again because there's so much information. Thank you. Thank you so much, Doctor. And yeah, I can see why she's called Dr. Moore, because I'd be happy to hear more.